I am particularly pleased to be hosting this event because the subject of the report is so well aligned with current UHF priorities. For those of you who aren't familiar with UHF, we are an independent nonprofit established in 1879, and we work to make a more effective healthcare system for every New Yorker. For 139 years, we've been tackling the most critical challenges facing New York through independent research and policy analysis, convenings and collaboration, and supporting and developing innovative programs. In addition to our ongoing work on expanding health insurance coverage and improving healthcare quality, our newest focus area, which we just launched this year, is called Clinical Community Partnerships. That is fostering collaborations between the healthcare delivery system and communities to promote health and well-being and to address the social determinants of health. We launched this new priority area this year because we believe that it is a critical step in achieving greater value in the healthcare system. We, of course, as a nation, spend more on healthcare than any other country in the world, but on broad measures of health outcomes, our performance is mediocre at best. And that's because although our spending is concentrated in healthcare, clearly the drivers of population health outcomes are often beyond the reach of the clinical delivery system. But just because these drivers of population health outcomes are outside of clinical care, that does not absolve the clinical care system of its responsibilities. In fact, healthcare remains so central to the lives of the many disadvantaged populations that we're trying to serve. Oftentimes, it's the only consistent window into their lives, so that we must create sustainable partnerships between the health and human services sector in order to improve health outcomes. And so I'm proud to have served on the HSC Commission on Value-Based Care that produced this report being released today, which directly addresses this issue of partnership between the health and human services sectors. So this morning, we're going to have Allison Sesso, Executive Director of the Human Services Council, begin with an overview of the report. This will be followed by a panel of reactors who will reflect on the challenges and opportunities from the report. We are extremely thankful and pleased to have on the panel Denard Cummings, who is the director of the newly created Bureau of the Social Determinants of Health at the New York State Health Department, LaRae Brown, who's president and CEO of both Interfaith Medical Center and the new One Brooklyn Health, and Margaret Crotty, executive director of the Partnership with Children and a member of the commission of the report. So I am going to turn it over to Allison, who again will begin with a brief overview of the report. Thank you and welcome again.
Thank you and good morning, everyone. I'm just going to pull the microphones down a little to more to my face. Don't notice that. So I want to first thank Tony and Chad and Sally for helping us organize this event this morning and being our hosts. I think it speaks a lot to the fact that we have a health-focused organization partnering with us on this release. And of course, also echo my thanks to the Altman Foundation and Rachel Pine for bringing us here. And of course, the entire commission for their work. And I will do a couple of thank yous. But I wanted to just say that I know that there's a lot of conversation and a lot of reports and focus on this integration. And what I think distinguishes this report, and I hope that was our goal, is distinguishes this report, is really adding the voice and perspective of the human services CBO side to the conversation and really talking about their business needs when we're talking about linking to the healthcare side and what those needs really are, and really thinking about the current operating environment that they're in, and so how can they effectively link into the system. And in short, it's seven recommendations. It's a blueprint forward, and those seven recommendations really, they, as I will talk about, need more work. They need more collaboration and discussion, but it's an idea that we need to look for the long-term evolution of the human services and healthcare field together. And these are the areas that we have identified will help the human services side really help with that triple aim that the state keeps talking about and that we are supportive of. So this is, you all have a fresh copy on your chairs. This is what the report, hot off the presses, as they say. This is what the report looks like. I just wanted to do a couple of thank yous before I go into the recommendations and a little bit of background. I said again to United Hospital Fund and to the Allman Foundation and also the Commission and our chair, who unfortunately couldn't be here this morning at the very last minute because of a scheduling conflict that came up. This is what happens when you get very important, busy people to chair your commissions. Lillian Barrios Paoli, who I was excited to have as a partner in this, and is so thoughtful and has been on so many sides of this equation, and really was the perfect person to lead this group forward. And so I wanted to thank her publicly, and I'm sorry she's not here to say this, so please let her know when you see her that I made these thank yous to her. And also, again, to the people who really led the commission and were part of the commission, particularly the chairs. There was a lot of work that was happening in between meetings, and it happened over a year-long process. And there was a little over 30 people that were engaged throughout the process. And really, it was amazing to me how many commission meetings were full and robust, and the robust debates. I want to also acknowledge our 2 consultants that were on this project that we hired specifically for this. Kristen Woodlock, who was really our content expert, and Mindy Liss, who was doing a lot of the writing along the way and did the very first draft of the report and some other iterations. And of course, Tracy Robinson, who there's one person on the phone, and it's Tracy Robinson, and she's on mute, so she should not say anything, but she's our senior policy analyst. She really helped drive this process from the beginning to the very end, really painstakingly making critical changes to the report and writing whole parts of it. And she had a previously scheduled trip to Italy that she's on right now. So she's here from Italy. We're international, and she's on the phone. I also want to just thank the whole HSC team. Iona Tan actually designed this report, so her skills are showing up here. The whole team did work in making sure that there were, every T was crossed, all of those kinds of things in looking at it. And so I want to thank the whole team, and Jason Wu in particular, for getting us to this moment of printing and to this event. So enough with the thank yous. I just think they're important to acknowledge all the people. So I want to start with, why do we even care? Why do we want to take these seven recommendations to heart? And I think it's about talking about what the value is and really appreciating of the CBO human services sector. And I use that term human services CBO because we say human services, then we learn that the healthcare side calls us CBOs. So human services CBO. So we're all on the same page here. And there's actually quite a bit of debate about language in the commission discussions. So human services are the architects of well-being. That means that they're helping with other challenges that aren't necessarily health-related, but the things that are really related to social determinants of health. And unfortunately, I think my perspective is that the sector collectively has a marketing problem, that there's not a great appreciation for the work that we do as a whole and what we do as a sector. There's sort of understanding about what childcare does and what aging services do and mental health and all separately. But as a whole, that we are architects of well-being is not really appreciated and understood. And so we're actually at HSC been working and plugging into a national effort to talk about human services differently and use this metaphor related to construction to really talk about the value of human services so that people can better understand the value that they bring to the table. And I'm just going to read to you 2 short paragraphs that kind of use this metaphor to talk about their value to the healthcare sector, which I think is a good way to start so that we see the value of what we're trying to do in human services. So, just like construction of a house calls for a strong foundation, maintenance and a team of different experts at different times, building well-being calls for a variety of interventions throughout the life cycle and can require more investments when life's storms hit. To create a solid foundation and maintain a strong house over time, regular upkeep is necessary to avoid more expensive disrepair, such as a hole in the roof or an electrical fire. Human services interventions that create social connectedness as well as fiscal and emotional well-being are the upkeep needed to avoid more expensive health problems such as heart attack, diabetic fit, or massive infection that are more likely to occur in the absence of preventive supports provided by CBOs. So to give you a sort of framework that we're trying to express in a meaningful way what human services really add. So with that, I want to point out that I stole this graphic from John McIntosh. Thank you for being here from Sea Change Capital Partners, and also Oliver Wyman, who recently put out a report called The National Imperative that really looks at the operational challenges and the values of human services. And this, what I like about this and why I stole it is because it really gives you a sense of the human services ecosystem, if you will, and shows that, it's not just nonprofits, but it's also government providing some services, but as you see at the top, but it's limited amount provided by government. Most of it's provided by human services CBOs. The dollars are primarily coming from government sources. That's an important point that I think is often misunderstood. The private dollars are clearly important down there on the bottom, but they're limited. And managed care, obviously, dollars are mixed in there. Some of them go directly, some of them go through government. But this, I think, gives you a good sense of where the funding comes from, the complexities of it, and also the breadth of the sector, right? That there's, it's a $200 billion industry nationally, which, as they point out oftentimes when they do this presentation, is on part of the airline industry. So it's a significant sector that we should be really thinking about that reality, that it's not this small, sector operating off on the side. And just to give you some numbers in New York, it's obviously very robust and significant in this state in particular and in this city. It employs 330,000 people. The budgets are small and large, so you have under 500,000, as much as over $250 million, so there's really range of size. Typical budgets, especially for the larger CBOs that do the bulk of the services, are 90+% operated with government dollars. I think that's an important point. New York State has 4,400 contracts with nonprofits, and New York City spends $6.5 billion on contracts with nonprofits. So it's a significant industry, and I thought that was important to point out, and the fact that I think in general that the breadth and extent of the sector is not generally understood, which is, I think, part of the issue. So the reason why I bring this report that we did in 2016 up, and I want to point out the main points of this, is because it really is foundational to the next step that we're taking with this report, and it lays out sort of the operational challenges for New York nonprofits that we talk about in the report. And I will say that, interestingly, at that time, so this was in 2016 that we put that out, and there was another commission that did this work, we talked about the Medicaid redesign going on, and at the time it was relatively new, and it was very much on the minds of the human services nonprofits involved in the conversation. And they were very nervous about the risks associated and the expectations of them to take risk. And when the second recommendation actually talked about Medicaid redesign going on in New York and their ability to come to the table, and talked about the need to capitalize that in order for it to happen, which is interesting because that's where we still kind of are in some ways. The main points, though, are that they don't have thick margins. They have very thin margins. 60% have no more than 3 months cash reserves, 20% are insolvent, and it's largely due to the way that they're funded with government contracts, which tend to, on average, pay, they say, like 80% of the full costs, and actually in the National Imperative Report, it was 70% of the full costs. So maybe we're doing a little bit better here in New York. I don't know, but it doesn't pay the full cost, and so the reality is the nonprofits are constantly operating, trying to keep their heads above water, and very thin margins, which is really important to how they're going to connect to the healthcare side, because they don't have the ability to take risk. And what we talked a lot about in this report is the importance of risk management. And if they're doing risk management and they're looking at their limited margins, they will see that they do not have the ability to take risks that are necessary for jumping into relationships. And so they won't, if they're doing risk management, jump into those relationships. So we need to think about that, and a lot of the recommendations sort of take into account that reality. And that's why I thought this was an important foundational point to make early on in this presentation. So Medicaid redesign. The triple aim is fantastic. I just want to say the sector fully supports this. It's a great set of goals, improving health outcomes, better quality of care, reduced costs. We're fully behind that. This shift from volume to value makes perfect sense, and we'd like to see that happen, and then some dollars to shift over time to support more social determinants of health, for sure. But I will say that within this context, there has been, in terms of Medicaid redesign, a limited focus on the needs of human services CBOs, and that's not a blame, that's a reality. And the need, and it's understandable because the shift in healthcare has been significant and it is still happening, and it's been rightfully needing to focus on that. But if we don't shift and also focus on the needs of human services CBOs, we're concerned about our ability to really make that connection to social determinants of health that are critical to attaining these goals. So the blueprint is really, as I said, 7 recommendations. The goals are really, these are the 3 general big picture goals of care is efficiently coordinated, risk is accurately calculated, and contracts and rates are reasonable. So with this blueprint, I just want to say that this is not like, okay, do exactly what's in this report, this is the exact thing, and this will solve it. What it does is it outlines 7 areas that need further deliberation and discussion, and it actually sort of deliberately asks for the state to take more of a leadership role in some of these conversations and to be more hands-on in making sure that these recommendations are further brought forward. So I just wanted to say that in terms of the blueprint and what to expect, this is, you don't have all the answers. You have more questions in some ways in some of these recommendations, but they're clearly the buckets that we think need to be further investigated, and we have taken them through our debates in the commission to a good place where I think we are pretty far along, and we will proactively seek to get them further conversation around them. So okay, the recommendations. So the first one we led with, which is bridge the technology divide, is obviously a pretty big ask. It's not easy. I mean, there's no expectation that this is easy, but I think it's also critically important. If we don't bridge the technology divide, the ability to make referrals, to monitor outcomes, all of the things that are going to help make this evolution happen is going to be undermined. And so while it's a heavy lift, I think in some ways, we think it's really important that we put our heads together and we figure out a way forward on how to bridge this technology divide. And what that means is that it's a two-way street on technology, right? That it can't just be that human services CBOs are giving data to the health side and then have a black hole. It's very important that we appreciate and recognize that human services CBOs very much want to evaluate their own performance, and in that means that they need access to data and information, and they need to have conversations and work in partnership with the healthcare side. And if they don't have access to that information, they can't be true partners. So right now, a lot of the relationships are like nonprofits filling out Excel spreadsheets and sharing them, and that's not going to work for the long term. The part of the problem is that human services CBOs, again, get most of their funding from government contracts, and with those come requirements and specific databases that they have to already comply with. So we have an example in the report of one CBO that has 26 different databases that are independent that they have to report into. That's pretty inefficient, to say the least. It's pretty expensive. And in terms of staff time and capacity, and it doesn't really have to be that way. So we need to think about that reality that they deal with, and also all of the investments that have been made on the healthcare side in the RIOs, and how can we look at those systems and make further developments to make the connection happen. What we specifically actually are suggesting in the report too is that the state consider investing in what we're calling a public good, if you will, then in quotes, because it's sort of like the government invests in highways, right? So at some point, technology becomes our way of communicating and interacting with one another, and I think in today's world, that's definitely true. And in this instance, it may make a lot of sense for the state to consider, if they want this integration to really happen, to help us connect to each other. And so nonprofits do not have the additional dollars or capital to invest in systems. And if we just gave them the capital, they'd all do different systems, which would not help this problem. So we really need to see if the state can take leadership and invest in a very basic system that everyone can plug into for free. And then if individual nonprofits have the capital and ability, they can add more bells and whistles to the program itself. So that kind of thing is what we were thinking about. Recommendation 2 is really just looking at the overhaul of rules and regulations and how they currently are made to an old system that was really process focused. And if we're really shifting to an outcome focused approach, then we need to review all of our rules and regulations that are preventing nonprofits from being more nimble and flexible and doing what they would need and what the healthcare system wants them to do to get to the outcomes. So One example is credentialing, and the fact that managed care organizations are creating their own approaches to credentialing. So now CBOs, in addition to what they have to comply with in order to do business on their government contracts, also have to comply with managed care organization new rules and credentialing and they're different. So that we think some leadership on this could be helpful. So that's really the rules and regulations recommendation, is to take a comprehensive look at that. Recommendation 3 is really about making investments that help the two sectors get to know each other more and have more interactions. I will say that the state has actually, under NARD's leadership, taken some action here. They've done this survey that's attempting to get information from the CBOs to share with the healthcare side, so they have a better understanding of what's available. There's been value-based boot camps. I will say that the Greater New York Hospital Association and New York Academy for Medicine just did a report on this, which I would think everyone should take a look at, that really talks about fostering the relationships between these two sides and what really works. So we just think there needs to be more deliberate action on this front as well. And we had a couple of ideas, one of which was creating a grant fund at the state level that helps to the nonprofits with the capital funds that might help them do value propositions and think about how they would connect to the healthcare side. And there actually is an example of the state creating a capital fund for nonprofits. Under Fran Barrett's leadership, the state did create a nonprofit infrastructure capital investment program at $120 million. That nonprofits, this is not. That fund is, just to be clear, is not for connecting health and human services necessarily. It's for general nonprofit capital needs. But we think that it's a model to look towards, that if we're really thinking about connecting these two, we may be able to look towards that kind of model. The fact is, it does exist that the state has a grant fund available for nonprofits to tap into for capital funds. And then other ideas were things like RFPs, like helping us on the human services side, really helping the healthcare side understand how to design RFPs that CBOs will really respond to, what needs to be in there, what won't be helpful. And then we had this idea that managed care organizations should have social determinant of health staff positions that are really dedicated to this relationship building. So those were a couple of the ideas. They're not the only ideas. We think more can be out there to make this happen. The next is really about, similarly, it's just about how to help nonprofits connect to the healthcare side, building off the last one. But by having more organized networks, you can sort of cut out some of these additional costs that each individual nonprofit has to do: risk management, do the contract negotiations, do all of those outcomes design and all of that on their own. As a network, you can streamline some of that and sort of cut down those expenses. And so we very much think that there should be more deliberate focus on these and the creation of them. There's been a lot of work done on the behavioral health side. The state has made some investment on this front. So let's look at those, and let's also figure out how we can build on top of those, right, to diversify them. So I think behavioral health, because of its funding coming from managed care, really sits in a unique place that straddles human services and health. And so let's build on that and add some more diversity of human service CBO solutions to those networks. The next one is about just contractual barriers, right? It kind of feels like a no-brainer. Like, let's create some basic contracts that the state can endorse that would make everyone's life easier and would protect against, and would take the risk realities that nonprofits deal with into account, right? So, like, let's not make the same mistakes that we've made with government and not have, the right indirect rates. Let's not have no contract escalation clauses, things like that. And let's think about the risks and the terms, and let's do that together in advance of entering a contract. Of course, with some flexibility within the contract, but I think some basic language would really go a long way. And there was actually an example also of thinking about this for standardizing billing. The ambulatory patient group is an example that was created by OASIS, in which they did a catalog of care procedures, and that was developed with weighted reimbursement rates. Pam Mattel actually brought this to our attention. And, what we understand is that it offered really predictability for the nonprofit and covered more of the full cost, which are the two things we really need if we're going to be successful. So number 6 is really about the measuring social determinants of health, and Arthur Webb really led the way on this front for our team. Making sure that they're not just overly clinical, but they really think about well-being and measures of well-being, and that we're considering that when we're developing them. And importantly, I think going back to the margins problem, we have to realize that we can't wait for the outcome to be materialized for the nonprofit to accept payment. They need to be paid at the time of intervention, at least at first as the system evolves and we're waiting to build up their margins. So that's a reality that we need to take into account, so payment structures need to really think about paying at the time of intervention and still evaluating for whether or not the outcome, got there, but they can't wait for payment for the outcome because they take a long time and measures need to appreciate that. And then the last recommendation is really about building on what I just said, shifting risk incrementally and commensurate with service level. So realizing again that this is an evolution, and that the nonprofits in the current state mostly cannot take on risk because of their thin margins. And so the arrangements that they have got to be pay for reporting and upside risk only. We can evolve to a better place, but we need to have our margins built up, and we need to change the business model in order for that to happen. So that's all of the recommendations. I am looking forward to next steps on this. HSC is not an organization that lets a report sit on a shelf. We will definitely be looking for opportunities. Please invite us to speak. Some of you have already done that, to talk about these recommendations, connect us to people that you think we should be talking to, let us know of opportunities, share this within your own newsletters with other people you think might find this of interest. And I want to thank the panel for agreeing to talk about this more, and I'm looking forward to that conversation, and I think I'm right on time. Okay.